Alrighty, good morning, everyone. Sorry for a little bit of our technical difficulties, but we will get started in just a second. Um,
Hello everyone and welcome to today's session. We are PreMed CC, a student-led organization established in the fall of 2021. Our goal as an organization was to create an online community for pre-medical students at community colleges and universities with the hope of guiding the next generation of diverse and inclusive physicians.
And while we advertise our organization as being for community college students, our events are open to anyone. We realize that finding guidance and mentorship in a pre-med journey can be especially challenging for first-generation pre-med students, people that lack the financial resources, or just those that do not know people in the medical field.
One of the best parts about our events is that they're virtual, so you can do it from the comfort of your own home. We typically have events on Fridays from 5 p.m. to 6 p.m. PST, and on Saturdays from 10 a.m. to 11:30 a.m. PST.
If you aren't able to attend the event, all our sessions are uploaded on our YouTube channel. Many of our sessions will end with Q&A with our speakers. Any questions that you have can be put in the Q&A section on Zoom, and our team members will read them and have them answered.
After you have attended our event, you can log on to our website and complete the quiz, which will contain questions pertaining to our session today.
If you score 70% or higher on the quiz, you'll be awarded a 2-hour mentorship certificate to show that you attended our session today.
If you want to stay connected with our upcoming events or want to tell your pre-med friends about PreMed CC, you can find us on Facebook, YouTube, Instagram, and TikTok at PreMed CC.
Welcome, everyone. So Dr. Julio Monterrey attended Santa Clara University for his undergraduate, where he majored in biology, emphasizing molecular and cell biology. Then Dr. Monterrey was accepted into the combined MD master's program at UC Irvine School of Medicine called PRIME-LC, which focused on preparing future physicians to treat underserved populations. After completing his preclinical years at UC Irvine, Dr. Monterrey attended Stanford University's master's program in epidemiology and clinical study design, where his research focused on neuroimaging in children with autism. After 6 years of dual enrollment at UC Irvine and Stanford University, Dr. Monterrey completed his MD and master's degrees and was accepted into residency at Stanford University for psychiatry. After completing his residency training in 2018, Dr. Monterrey opened a psychiatry clinic in East San Jose for low-income families and worked with the County of Santa Clara to provide psychiatric care to low-income people. He became medical director for 7 clinics, including a geriatric psychiatric clinic, an adult psychiatry clinic, and several pediatric psychiatric clinics. He has also served as medical director for a national telebehavioral health company and currently works in his own private practice in the South Bay. Welcome, Dr. Monterrey.
Thank you, Mindy, for the introduction. It's a pleasure to be here, and I want to thank everyone that's attending early Saturday morning on this very important topic. I think the approach I want to take is one of being action-oriented. I feel like a lot of topics, we all talk about and we want to get educated on, but we also want to really focus on, okay, we understand, but then what are we going to do? So I kind of want to take that approach to this conversation. So, everyone listening in, get your coffees, your teas, your matchas, whatever, settle in. Let's have a conversation about, mental health and in general, and what you can do as a pre-med. What is psychiatry about? Where is the field going in general? How's the country, how's the population, how are people doing in general? So it's going to be a little bit broad, a little bit of everything, because I want you all to kind of think broadly and then think about what you can do. All right. So I first want to start off with kind of talking a little bit about um, what psychiatry is, honestly, because So when I went to medical school, so I guess to step back a little bit, um, so I initially wanted to be a vet back in high school, and then I was like, okay, I need to educate myself on, well, what is it like to be a vet? Like, is that what I want to do? And I did that. I volunteered at like, vet clinics, and eventually I was like, I kind of like human medicine. I love animals, I love dogs, but I'm gonna focus on human medicine. So I early on I went to a medical magnet high school. So Andrew Hill, if anyone knows Andrew Hill or Eastside Union High School District, shout out to them. So I went there and eventually, became pre-med. And as you all heard, I went to Santa Clara University. And the whole time I was like, okay, I want to be a physician. I didn't quite know what kind of physician I wanted to be. I'd like the science behind it. So I went into med school kind of open-minded, debating between, okay, am I going to do surgery or like non-surgery? And I was like, oh, surgery sounds really cool. Maybe I'll do that. And in med school, rotating through all the different rotations, I loved all of them. So it was really hard to pick. And I actually didn't pick psychiatry until kind of the end. It was a somewhat of a last minute decision because I liked so many different things. And so what ended up happening was every rotation I was in, um I came back to the mental health aspect of illness. So for one example I'll never forget was, so I was at UC Irvine, and there was a patient in the ICU that was Spanish speaking, monolingual, young female patient. uh, she had come into the emergency room in respiratory distress. She wasn't able to breathe. Her diaphragm had paralyzed, and she was induced into a coma. So we were rounding, and they told me, yeah, this patient has myasthenia gravis. So those are antibodies against these receptors that are going to turn off your muscle activity. So her diaphragm paralyzed. She couldn't breathe. They said, she's going to come out of the coma. We don't really know what happened. So we want you to interview her as a medical student and find out what happened. So when she finally came out of the coma, I went in there and I started speaking Spanish with her and figuring out what had happened. And she told me, well, leading up to this event, um, she had been essentially sexually harassed by her boss, and that had been happening for several months. She had told her husband, and her husband was critical of her, actually. It's like, what did you do to put yourself in that situation? And didn't really understand. And then the last straw was the boss kind of, really pressed himself on her at the workplace. And after that, overwhelming feelings of guilt came over her. And slowly later that day, that it was a flare up of that autoimmune condition to the point where she couldn't breathe, ended up in the emergency room, ended up getting intubated, going to the ICU. I mean, if it wasn't for medical intervention, she would have died. And I was just blown away by the idea that here was this condition that I had studied in the neurology section of, our preclinical years, of this like antibody and these receptors and this very molecular thing, very kind of mechanistic pathophysiology. And yet it was triggered by a cognitive stress. Um, of what had happened, that emotional stressor that she had been going through. And to me, that was fascinating. And I just never forgot that. So I went on through the rest of my clinical years, third and fourth year of med school. And every rotation I was in, no matter what it was, surgical, non-surgical, I kept coming back to the whole mind-body connection. And the very last thing I attended before I decided for psychiatry was immunology, rheumatology grand rounds. So I was visiting Stanford, and I went to their grand rounds in rheumatology. Imagine this huge auditorium, about 100 physicians or, physicians in training. And the case was so complex that the patient was actually there, and they were on stage and they were sharing their experience. And the reason it was complex was because his presentation didn't fit any kind of clear diagnostic picture that we know of. He had symptoms that just didn't quite add up. They did some genetic studies on him. Turned out he had some mutation in an interleukin, forget exactly which one it was. but his symptoms were just waxing and waning, didn't make sense. And so everyone's asking them questions, trying to figure out what the diagnosis is. Like, is this really that mutation or is it something else? And to me, the most interesting part was when he said, I know when I'm going to get a flare up of body swelling and pain because a day or two before that happens, I wake up feeling a little sad. And he's like, I was doing great. Everything was going well in my life. And for just no reason at all, one morning I wake up sad and I know because this is what's happened before. Soon in a couple of days, I'm gonna swell up. I'm gonna be in tremendous pain. I'm going to be basically incapacitated. And everyone's like, okay, everyone's talking about, okay, well, what joints are involved and where's the swelling? How bad is it? And all these things like, do you have a fever? Blah, blah, blah. And I'm sitting there thinking, well, wait, he just told us it starts, with a low mood. What is that about? Again, mind-body connection. So I just realized there's nothing I can do. No matter where I go, my brain goes back to mind body connection, and I'm a psychiatrist. Like that's what I need to go into. So it was late that evening. I can tell you that moment. That's when I decided that I had no choice in a way. I had to be a psychiatrist, and honestly, since then, it's been amazing. Every year that goes by, I love my field more and more. It's an exciting field. You can, and we're going to talk about this, this is why I'm kind of giving this intro about what psychiatry is about because it is so broad. You can practice psychiatry as the psychotherapist that kind of we've all seen in Hollywood movies, just sitting on the couch, talking, or you can be a psychopharmacologist, which is really focusing on the pharmacology, the neurochemistry of the brain, as well as the body, because it's all connected. You can be involved in community psychiatry. You can be involved in inpatient psychiatry in a big academic center. You can be involved in subspecialties depending on the population. So you can treat pregnant people in mental health. You can treat geriatrics, pediatrics, sports psychiatry is a thing, right? So we've all heard or if you haven't, it's coming up more and more out in the open that people now, professional athletes, go to psychiatrists to really optimize, their perspectives because that is going to influence their physical performance. So there's this whole movement also of positive psychology. You don't have to wait for something to be wrong to go basically get a tune-up, a mental tune-up that will come out as increased productivity in your day, better physical health, better relationships, overall happier. Then there's like the neuroscience of it, which is a fascinating, ever-growing field. I call it the final frontier. I mean, it's one of the parts that we know the least about in the body. We can see out into far into space, light years away, but I mean, tell me where there's an emotion in the brain. We talk about, oh, the amygdala, oh, this like structure in the brain. Where's your memory of, your first pet? Like, where can you point to it? We can't. We have no idea, right? And so it's really the final frontier. It's tons of discoveries. It's moving super fast and super exciting. So since I decided on psychiatry, I love it. You're both a one of the things I liked about it was that I said, I want to be a specialist. I want to feel like I'm an expert in something. But I care too much about big picture. I care too much about communities and society and where are we going in general as a people. And so I'm like, how can I be so broad and yet also specialized? And I felt psychiatry really fit that because in psychiatry, obviously, it's the individual and how they are interacting with their environment. We talk about a biopsychosocial approach to a person, to what they're dealing with. So you're integrating everything, their biology, their psychology, their environment. Um, so it's very broad. So I love that. And yet also you are a specialist basically in the neurochemistry of the brain. So that's, so the more I've thought about psychiatry, the more I've come to appreciate it, the more you practice psychiatry, the more fun it actually gets. So when I first became exposed to psychiatry, I was a first year medical student. It was a Friday night, and one of my mentors invited me over to the inpatient locked ward. And I kind of wanted to go out, to be honest, on the Friday night. I was like done with all the studying for the week. But he gave me this opportunity, and I was like, I don't know. I don't know much about psychiatry. First year medical student. Let me go in. And so I go in, and it's again Friday night. So he starts rounding, and there's this patient that's super nervous. He is, I don't know what he has. I don't know anything at that point as a first year medical student, or I don't know much. And the patient was very nervous because um, the physician, the attending, was going to go away for the weekend. And he's like, what's going to happen if I feel super nervous and super anxious and I feel like I'm going to die, panic attacks, what am I going to do? And we were sitting in a round table, and this man was shaking and sweating, and you could feel the anxiety and the stress and the the discomfort, that he was going through. And I started feeling anxious. And I'm like, this sucks. Like, I don't want to be feeling this way. It's Friday night. Like, what am I doing here? And I'm looking at my attending, and he's just totally relaxed. And he's like, you know what? He tells his patient, so and so, have I ever done you wrong? No, right? Okay. So you're going to be in good hands. We have good staff here. I'm not going to be here, but my resident's going to be here. If you need anything, you let us know. We take care of you. He's like, okay, okay, sweating bullets, shaking, overwhelming, right? For me. So we go back to the workroom. Tanny puts on his headset, starts dictating his note, takes a pause, and I'm just like standing off in the background. And then I'm like, kind of when there's a little moment, I squeeze in there and I ask, um, Dr. McGuire, do you ever get nervous, when you're assessing these patients? And he's like, dictating. And he's like, no. And he keeps on dictating. And I'm like, in my mind, I'm like, this is not for me. There's no way. And then he just kind of keeps on dictating, and then he pauses. And then he doesn't even kind of look at me. And he's just like, very quickly, you're going to find out you're not God. And I'm like, what the hell? Like, what does that mean? And I thought about it, and I thought about, well, why was it that I was getting nervous? Well, it's because I really wanted to help him, and I didn't know how, and I felt powerless, and I was anxious to help, and I was stuck. And so then it started making sense what he said to me, like, we do what we can, and there are just some things that are just, they're going to be the way they're going to be. And that actually, honestly, in a way, kind of cured me. Like from that moment, I said, I'm going to try my best. Um, but there's only obviously so much we can do. There is suffering in the world. I mean, that is a reality. Tragedies do happen, and we can't undo that. And, it's okay to feel sad and feel nervous, and we're going to help as much as we can, and as providers, we have to remind ourselves that, yes, we're not God. We cannot fix everything, but we're going to try our absolute best to help you. So, you know, um, that was my first experience of psychiatry. And from, not knowing anything about the pharmacology or the diagnoses, the diagnostic criteria, and all the intricacies and the connections between the mind body. And, from that point on, the more I learned about psychiatry, the more I learned that there's just tons to know and learn, and it never stops. Like I'm constantly, reading, brushing up on all the diagnostic criteria because there's just so much to learn, and it's really fascinating and it's exciting. So, um, psychiatry is so broad, and it gets confusing in terms of who are mental health professionals, right? Like, and like what they all do. So, um, because again, I didn't think I was going to go into psychiatry. I didn't know the distinction either. So let me kind of share with you a little bit about that. So, um, everyone knows about like psychotherapists and psychoanalysts, right? Okay. So just to clarify, psychotherapists are people who can do psychotherapy, and there's tons of people that can do it. A psychiatrist can get trained in psychotherapy, and you get that training not in medical school, but in your residency. Licensed clinical social workers who have master's degrees get training in psychotherapy. Some of them end up focusing more like on case management stuff. Some of them end up focusing on case management and psychotherapy, and some just do exclusively psychotherapy. So they can do that. Licensed marriage family therapists go to school for psychotherapy. And then there are other degrees also that can do psychotherapy. So lots of people can do psychotherapy, including a psychiatrist. So a psychiatrist could be a psychotherapist. They are also a medical doctor, right? They went to medical school. So, and your specialty is basically, yeah, knowing psychotherapy, but also the neurochemistry of the brain, and obviously physical physiology, right? So when you dose a medication, what's the renal function? What's the liver function like? Drug-drug interactions, interactions between the drugs and any medical conditions you may have, et cetera. So that's psychotherapy. That's where psychiatrists fit there. Obviously, the psychiatrist being the physician of that whole group of people, we're the only ones that can prescribe. Now, there are other now special fields that are growing that are able to prescribe, like nurse practitioners, but that's kind of the general breakdown. So the way I practice, and I said that there's multiple ways to practice the psychiatry because it's so broad. The way I practice now is I'm an outpatient psychiatrist. So I'm out in my clinic, I have a private practice. My approach is a very medical one. So I look broadly at the person, kind of what are your medical conditions? What's your environment like, your social life? What are the mental health issues that you're struggling with? And I formulate a treatment plan. And so I really think of myself as a primary care doc for your mental health, because it's my job to understand what are all the psychotherapies out there, like psychoanalysis, cognitive behavioral therapy, dialectical behavioral therapy, acceptance and commitment therapy, prolonged exposure. I mean, we can go on and on, EMDR, all kinds of stuff, right? So my job is to know about all that. My job is to understand you and what you're going through, what you want in your life. I know the pharmacology, I know the therapies. I'm going to put those things together and give you recommendations and treatment plan. Then I will refer you to therapists or further diagnostic work or some other specialist, and you kind of come back to me to give me updates, and let's reevaluate, make sure we're on the right track, that you're getting progress. Always, moving forward. I want to see forward movement. So that's how I practice. And I encourage anyone that is interested in psychiatry to talk to a lot of other psychiatrists, because we all kind of practice a little bit differently. Some again are in the hospital, some are interventionalists. They're doing transcranial magnetic stimulation. That's a machine that, the wand is the size of a cell phone. You put it over the left part of the brain, you stimulate it using an electromagnetic field. And you're essentially, as far as we know for now, probably will change, turning on circuits that are off in depression to treat medication-resistant depression. All right. There's also other interventions like ketamine infusions, ketamine nasal sprays, etc. So very broad practice. And so lots of opportunities for anyone that goes in psychiatry or mental health to really help communities in their overall well-being, because you can just do it all. You can do it in the clinic, hospital, you can do it out in the field. So I do that too, right? I go out, sometimes I will meet my patients at home or somewhere else. We can do exposure therapy, where if someone's dealing with social anxiety, like we can actually go to Santana Row and we can, guide them on how to talk to people out in the field. Again, very action oriented, kind of let's get this done. So, all right, that's kind of the broad kind of scope, I would say, about what psychiatry is about. There's lots more to talk about, but I want to kind of move on to the diagnosing and the treating of mental illnesses, and understanding the cultural kind of influence that these things have on our diagnosing and on our interactions with our patients. So a very interesting concept in psychiatry is that the way that that disorders manifest. So I was told by my attendings at Stanford that in the 1990s, there were tons of people in the inpatient locked ward that said that they were possessed. That was like, they would be admitted because they were disorganized, They weren't able to care for themselves. Sometimes they were a harm to themselves. And well, when I was there, I never saw, well, I saw kind of one, but it wasn't as prevalent as my attendings had told me. And so we were like wondering, like, that's very interesting. Like, how does that happen? And there's this idea that mental health conditions manifest differently across cultures and across time. So it's kind of like our brains take what's around us and then process it and then kind of spit it back out in a way that others around you at that moment in time will understand you. Let me give you a little bit of an example. Why is it that when someone suffers from depression, like, or sadness, not always, but most of the time you can kind of see it, right? So like, imagine you're in class, you come out of class, you're walking out of the classroom, and then you see someone sitting by a little bench, and they're sitting like hands crossed, head down, not really moving. Immediately, even if you don't know that person, you're like, what's wrong with that person? So what might you do? You might walk over there, and then you might say, hey, is everything okay? Right? That's powerful. That's our natural circuitry in our brain going off, taking over. That's our evolution taking over and saying, I am going to shut this body down and physically communicate to the people around me that I'm in need. That's how depression manifests, right? And so it's ways to communicate the need for help. So it's very interesting that in cultures where the idea of demonic possessions exists, that is kind of how some things will manifest. So, and then you go on, from culture to culture, depending on their environment, that's how it will manifest. And so that does make it challenging for a psychiatrist then to be able to understand where is this person's, what's this person's culture, how are their conditions going to manifest, and then try to match that up with a very kind of Western understanding of mental illness presentation. And we're doing a better job. There's a whole section now in the DSM. This is the diagnostic manual. This is our Bible per se for diagnosing. There's a section now for more culturally understanding presentations of mental illness. So we are getting better at that. But this comes back to the need for diversity in medicine. And this is where all of you come in and all of your diverse backgrounds. And it is crucial for our field to have people from all walks of life, from all different types of cultures to join psychiatry and be able to understand and connect with patients because it is crucial to our ability to treat people. We need to be able to connect with our patients in order to be able to influence change. They need to trust us. They're telling us their scariest thoughts, the things that have happened in their life and no one else has ever heard. And you're not going to, be comfortable saying that unless you're talking to someone that you can trust and are comfortable with. So it's important for us to be diverse as a health field. I think one of the unique challenges that cultures, many different cultures have is the stigma, right, of mental health. And I recently actually started working on a segment on Latino mental health, specifically Latino men and the barriers that they have for seeking help. And this is something that will come out probably in Univision like later next month. And my kind of the take home point I gave was, there's a big push in our society to rethink of like what it means, what gender means, what cultural biases we have. And that's amazing. That is honestly a level of awareness of our newer generations that is great. It's going to allow for equality to really kind of come in. It's a necessary first step. when I have a patient though come into my office, if I tell a Latino man, hey, we're gonna start off by kind of redefining what it means to be a man. You know, like what you thought was a man is not really a man. That's not gonna go well. Let me tell you. Why? Because I'm not meeting them where they're at. This goes back to the cultural sensitivity of things, right? You need to meet the person where they're at. It's not about me and my ideas. It's about me helping that person. So I focus on, well, what's bothering you? What keeps you up at night? You know, how's your relationship with your family? With your friends? How are you doing at work? Go to the ground, right? To the real stuff. And then you kind of work your way up. And then they realize over time that yes, their concept of what it meant to be manly, you know, isn't necessarily true, but you take them on that journey there. You don't kind of jump to the conclusion and it'll feel judgmental, if we go straight to that point. So that's one thing that I kind of want to wrap up and say is that as pre-meds, people who are aware of health issues in our communities, and you are literally pursuing a career in health, you don't have to wait, until you're a psychiatrist, until you're whatever else to be able to help. One of the ways that you can help is by normalizing seeking help. Um, Really push, like I want you, I shared with you the idea of positive psychology because I all want you to really push for in yourselves and the people around you that you don't have to wait for there to be a problem for you to benefit from being able to talk to like a mental health professional. It doesn't have to be a major problem. You don't have to wait for it to be a catastrophe. Um, by nature, let me go into a little bit of the neuroscience. By nature, our brains are predictive machines. That's how we're wired for survival. We're wired to predict threats. Okay. That's what we do all the time, whether you want to or not. And because we are predicting machines, and sometimes we are right and sometimes we are wrong, and sometimes when we are right for the wrong reasons. In other words, what we thought was going to happen, happened, but not for the reason we thought it did. But we don't know that. And so what that develops over time is a collection of cognitive distortions. So if you live life, you are collecting cognitive distortions over your life. So it's a beautiful thing to be able to go into therapy and just talk about things that you thought you understood in you. And the therapist is going to untangle and expose your cognitive distortions. You're going to be like, wow, I had no idea that that wasn't the case, or that didn't happen because of what I thought, or I'm not actually like that and I thought I was. Or I am this way and I thought I wasn't. It's fascinating. So um what I want you all to really think about is more positive psychology, moving forward, helping people feel better, not having to wait for a catastrophe, as well as normalizing that these truly are illnesses, okay? No one wants to be depressed. No one wants to be clinically depressed. No one just says, I just want to get depressed today. No one says that. And I have patients, that tell me my life is going well. There's nothing wrong with my life. And I feel extremely guilty that I feel depressed and I can't work because there's nothing wrong. It's a clear example of how these conditions are illnesses. Not everyone will suffer from depression, even though it's very common. I mean, that again shows you the illness nature of this condition. And so much like you catch a pneumonia, even though you didn't want to, you treat the pneumonia and it goes away. You can catch depression. You treat the depression and it will go away. Some people are prone to depression. So they can keep getting recurrent episodes. The more episodes you get, the more likely you are to get the next one. And so at that point, people say, well, you know what? If I'm not getting any side effects and medications, or if I can afford therapy, then let me just kind of keep doing that so that I don't get depressed again. It's like taking a prophylactic, meaning a preventative antibiotic for a pneumonia, for example. So normalizing that, it's not addiction is another one, a very important one. People feel like, oh, well, they want to drink, they want to do this drug. You know, it's kind of like I always think about breathing. I've been breathing, you've been breathing without thinking. However, I can hold my breath. I can breathe faster. I can control my breath. Just because I can sometimes control my breath doesn't mean I can fully control it. It's the same thing with like addiction. Just because they can kind of control, how much they use doesn't mean they actually have control and that this is actually a choice. No, there is wiring in the brain that predisposes people to addiction and gambling and substance use. And it's complex. In some people, it's a combination of what they've gone through in their life, um, their ability to handle stress, other mental illnesses, like anxieties or more severe conditions, like schizophrenia or bipolar disorder. Um, it's going to be a mix of all these things, but I want you all to also walk away with these conditions are real. They have they have real life consequences in your life. They have real life consequences on your body that we can measure. Um, and uh and so these illnesses are real. They really do require treatment. um there's no shame in requiring treatment because there's no shame in catching a pneumonia, for example. It's no one wants it, you just need the help. And also, just like the field of primary care has moved to preventative medicine, we can do the same in mental health. Like, let's get that awareness out there for people to be able to check in and untangle your thoughts and not wait, for catastrophes to happen in order for you to really live a fulfilling life and have clarity in terms of where you're going. Um, so I think I've kind of spoken a lot about different things. I want to, check in with everyone and be able to answer questions because honestly, the field is so broad. Um, I wanna, I wanna, I want this to be for you all, get the most out of it. So ask me any questions you want, in terms of the career, in terms of like the practice, in terms of what we can do together to really improve the mental health of all people.
All right, so our first question we have in the Q&A is, what is a post-bac? Is it only for pre-med students that don't have other requirements to apply for medical school?
And that's a good question. So, the post-bac is either for people who have not had all the requirements for med school, or for people that did that feel that they could do better, and they will go into a post-bac to essentially get better grades. And I think the thing to know about post-bacs is that a lot of schools will have their post-bac, and the med school is looking closely at the people in that post-bac. So if you have a school that you really like, really consider looking into that post-bac, because it might give you higher access to the staff and the admin of that med school. So then you become honestly kind of higher chances of getting offered an interview and getting accepted, not because it's preferential treatment, but just because of the natural psychology of things. Like we want, someone who's making a decision about who's coming into this med school. I'd rather know who I'm getting than to take a gamble with someone else. And if I have seen you over the past year, on campus, and I've seen you in the library, and we've chatted a little bit now and then, and you have good grades, between you that have good grades and maybe someone that has slightly better grades, but I don't really know them, I might go with you, right? So, that's what a post-bac is, and that's what I would recommend in terms of like choosing a post-bac if you have the option.
Excellent. Okay, so next question. When thinking about working with Latinx communities, how do you address social determinants of health that may come up when getting a social history? Would it be okay to connect them to resources in the community?
Yeah, so gosh, there's like so much to say there. Like family dynamics, like I have kids who come from families where um they're not that supportive. It's not like they are being mistreated and abused. So this is not like a CPS situation. However, and these are like young kids, for example, right? Like maybe like say 10 or so, where they're not, independent. They can't go, live that easily somewhere else. Um, it is super tough. I would say that's for me, for everyone, they're gonna have their tough, the cases that are tough for them. For me, that's one of the tough cases because I do feel pretty stuck. I'm like, I'm seeing them. I'm talking to them, maybe I'm doing therapy with them, and the whole time I'm like, it's your home environment, and it's like, how do we get you out, but we can't. So that's a very tough one. And the way that I try to manage, even though this is not always possible, is through case management. So the physician, the psychiatrist, evaluates, generates a treatment plan, and and then you actually treat, right? So who's doing the treating? Well, if it's a medication I prescribe, you take the medication. If it's like checks, like, hey, how is this kid doing? Are they eating? Do they have access to food? Um, are they safe? Unfortunately, I don't have the time to go over there, so it becomes a case manager. So case management is crucial when you're in the hospital and you're in the psych ward, or actually probably any inpatient service, whether it be medicine or whatever. The hospital is there to stabilize you, okay? But you're gonna live the rest of your life out there. And we need to set you up. If you're rehabbing from a fractured leg and you're coming out of the ortho service, you need to go to a nursing facility to rehab. All of that is set up by case management. And in psychiatry, it's case management is going to go in and ensure safety and make sure that needs are being met. And so case management to us physicians is like, God, like, thank you, because honestly, everything I've done in the hospital, everything I do in my appointment with this patient doesn't have an effect if case management is not in place to actually make it happen. So that's, I think, the biggest barrier, because unfortunately, there's not a lot of case management. The case managers that I have worked with have been in county clinics, and there's just very few of them. As you may recall in the introduction, I was in charge of 7 clinics, 7 community clinics. I was the only psychiatrist. That's sad, like that was tremendous amount of work, and I nearly burned out. And I had case managers helping me out, and that was about it. Like that, it was there's very few other clinics where that was the case. And so, talking about mental health field, being a physician is, I mean, I love it. It's awesome, but we're not the most important. Everyone has a role. And, if you're going to go into medicine and if you're going to go into psychiatry, it's because of a couple of things. Number one, that you actually like the science. Okay. You like the science of psychiatry. You like the medicine of it, and then that you actually like the work. Because if you like the work but don't like the science as much, there's other options, right? Like there's like the therapy, there's the case management that I'm saying. As an attending, I'm telling you, like, crucial. Like my plan is nothing if it wasn't for their help. Um, so that's the practical way that I approach those challenges.
Our next question we have is, how can we work to reduce stigma among Latinx communities to access therapy and psychiatric services?
Yeah, I mean, I think that's like one of the million-dollar questions. And so far, my answer to that is that we push for the idea that these are true illnesses, like diabetes, like hypertension, like heart disease. Um, and so, and to take that blame out of the patient and just say, like, I know that you don't want to feel this way. I know that you don't want to be this way, and this is something that you have been afflicted with. Okay, that's one. Two is really focus on the practical, because people still feel a little bit shy about how they feel. And so look at how it's affecting their life. And so, if they're not able to go to work, or if you feel like your relationship with them has distance, it's like, hey, I feel like we don't talk as much as we used to. I feel a little bit distant, a little bit disconnected. And I wonder if it's because you don't have the energy, and maybe you should kind of get the help with that, as opposed to um, kind of blaming or putting it like on the person like it's their choice. It's be a little bit more practical. Um, and then finally the idea of the positive psychology, right? That the same way that you go in for a yearly physical, this doesn't happen yet, and I'm kind of working on this happening. I would love to promote like a yearly check-in for mental health. It doesn't have to be with a psychiatrist. Um, it could be with any other mental health professional. But I think that when when a person gets exposed to mental health services and they realize how much they help them, you know what everyone says? They all say, I can't believe I didn't do this sooner. Why didn't I do this sooner? It is so helpful. Um, so I think that, you know, hey, this is an idea for pre-meds that want to go into mental health. Let's work on that, right? Let's work on maybe creating an annual little fair, to where there's screenings and then you have actual therapists there to do what we call brief interventions for people to get a feel for, hey, you're not coming in and talking about, things that you don't feel comfortable with. We're here to be supportive. We're here to actually help you. It takes the fear out of it once you kind of like know what it's about. Once you do it, you realize there's nothing to really be afraid of.
Right. Next question. What is the most common resource you notice that your patients need?
Most common resource would be psychotherapy. That service. So I always I always tell my patients, look, my job is to evaluate, get to know you, what you want to do in your life, diagnose because if we have the right diagnosis, we know how to treat. The studies have been done. We know what works. We know what doesn't. And whenever you all hear, I went to this therapist or I went to this, psychiatrist or whoever, and what they told me didn't work, there's basically two main reasons why it doesn't work. Either um either it's the wrong diagnosis and so they're treating the wrong thing and that's why it's not working, or to be honest, it's non-compliance. So non-compliance is they don't take their medication every day or they are not going to therapy with the appropriate frequency. When we do research on psychotherapy, we realize that there is a dose effect. Every session you have is literally looks like a dose when you look at the response. So if you take your psychotherapy every week, you are compliant, and you see the benefit. If you go sporadically, you don't see the benefit. That's kind of like non-compliance with medication. Um, so psychotherapy, I think, is the resource that is mostly needed, because a lot of conditions can be treated with psychotherapy. Let me give you an example. So major depressive disorder, depression, right? Not sadness, right? Sadness is normal. Like bad things happen in your life, you're sad. That's not depression. Um, it is if it goes really, if you go really deep and you're not able to get yourself out of it. By definition, it has to go be like 2 weeks of low mood consistently, and you can't come out of it. Then you start to meet the criteria for major depression. Major depression disorder research shows that psychotherapy and medication over the next two months is equally effective, equally. So I tell my patients, look, if you don't like to talk, you're gonna have to take a pill. You don't like to take pills, you're gonna have to talk. Either one is fine. You're gonna get better. If you do both, probably you'll get better faster. Um, so, but that my point there is that, you see psychiatrists prescribing, well, they could be referring to psychotherapy. And I much rather refer to psychotherapy because it's medication free, essentially side effect free, highly effective, equally effective. The barrier is the cost. And that's a whole different topic that we can certainly talk about and brainstorm ideas on how to bring that cost down. But that would be my answer. Psychotherapy is the number one needed resource.
Right. Our next question we have is what sort of cultural adaptations are coming up in the DMS-5 manual?
That's great. Um, so psychiatry is organized
Can you explain to them what the DSM-5 is?
Yeah, that's a great point. Thank you. Yeah. So DSM-5, this big old book here, is the diagnostic and statistical manual for mental disorders. So this is how we define mental illness. Because like I mentioned, so if you're sad, that doesn't mean you're depressed. It's normal to feel sad. So we need to come up with a way like how sad do you need to be to be considered having major depression, right? ADHD, running around, not able to focus. Well, if you didn't sleep, you can't focus that well. If you're stressed out, you can't really focus that well. If you're depressed, you can't focus that well. And so, how do we define, ADHD? Is it a lack of attention, lack of focus? That's part of it, but there's more stuff to it. So, literally, this is the list of definitions and the statistics. How common do things occur? Um, you know, where is our threshold? So for those that like math and statistics, we basically have to do these factor analysis. Like we write down all the different symptoms and we say what's the minimum amount of symptoms that we need in order for it to consistently describe a group of people that suffer from a condition. And part of the criteria will be uh not being able to function in your life. That is always a criterion in the diagnoses. In other words, if you are anxious, but you live your life, you're effective, and all of that, you technically do not meet a criteria for a disorder because you're functioning. Unless you feel in a lot of distress and you're not comfortable, then that counts. So how is this tied into the question? That is our attempt to not overdiagnose people, not just say, oh, you're this, and that, you got anxiety. Either you're this and that, you got depression. No, it's like, are you functional in your society? So like if you think back, back in the Greeks and the oracles and they're predicting the future and they're seeing things, they're having visions and whatnot. Technically, if they have food and shelter and they have a place in society and they are respected and they live their life, you technically don't meet a mental disorder criteria, right? And so that's our way of kind of, you know, protecting that the fact that people live in different contexts. And it is only when the person is not able to function in their life that the symptoms are then they arise to the level of what we call a disorder.
All right. So next question, how do you see that mental health differs in the immigrant population?
Yeah, good question. So first off, the immigrant population is very diverse. And they've all come from the people immigrate to this country for so many different reasons, different socioeconomic statuses. Besides the obvious that they come, immigrants are having, they're coming with experiences that US born people, haven't gone through. Um, Besides that, the one of the things that I see a lot in this population is um that they're kind of here to this is not their home country. And so very interesting. I've had to ask, if I ask them even if it's a medical question, like have you ever suffered from like high blood pressure? Um I encourage all of you to do this and you'll be fascinated by the answer. If you ask them, have you ever suffered from high blood pressure? They'll say, oh, no. And then if you ask the same question, you say, back in your home country, have you ever suffered from like diabetes or high blood pressure? Oh, yeah, yeah. Like, why don't you suffer that in this country and you did, 3 months ago in your home country? I don't know. Like, of course you suffer from that. Like, it's in you, right? But when people come to this country, from what I've noticed, it's like it's just a completely different mindset. This is not their home country. They're here for whatever reason to survive, to make money, to send money back home, to temporary to get an education, then go back home, whatever it may be. And it's kind of like not their life in a way. It's just something I need to do. Um, to get to where I want to be. And so what that means is kind of a little bit of blinders in terms of like the things that they've struggled with in the past that maybe doesn't apply here. That's one. Two, that they're not deserving of services here because I mean, depending on their migratory status, if they are not documented, they're scared, which this is part of like the segment I've been working with on like the Latin TV channels is telling people, reminding people like, hey, there's HIPAA. This is private. And in mental health, there's an even added layer of privacy. So when you go in, no one's gonna ask you about your migratory status. No one's gonna point the finger to you. You are safe to come in to receive help. That's one fear, right? The other though is like not deserving. Like I'm not a part of this society, so like, I'm not gonna plug into services. I mean, the reality is, right, that like anyone that lives here, you're paying taxes every time you buy something. You are contributing to the growth of our economic growth of our communities. Whether you like it or not, you are physically here, so you are part of the community, whether anyone likes it or not, whether you like it or not, it's just a reality. And so, of course, we should be providing, services to everyone that is here. Um, so I think that mindset of not belonging, of not deserving, or of things not counting, like, I'm sick. Again, I got a pneumonia. Well, if I was home and I had to deal with this forever, I go get it treated. But since I'm only here temporarily and I don't know if I'm going to move cities, I won't deal with it. No, I think that mindset is a very interesting one that I think we should probably study a little bit more, bring more awareness to it so that providers can really directly assess it and not miss things.
All right. Our next question we have is, do you learn different things in med school as a psychiatrist compared to other doctors, or do you start focusing on psychiatry in residency?
Yeah, that's a great question. So, um, psychiatry is a specialty like any other. And so there is no difference. Like I could have gone to surgery, I could have gone to plastic surgery, could have gone to internal medicine. It's the same training. Psychiatrists are specialists in neurochemistry. Um, and the brain, let me put it this way. The brain right now is divided essentially into three three groups have taken over the brain: neurologists, psychiatrists, and neurosurgeons. Okay. So if you're going to operate on the brain, you're the neurosurgeon. Then the rest of it is non-surgical, psychiatry, neurology. The difference there is if if you want to focus on motor movement, right? Um, and then you're a neurologist. You have a stroke, you're paralyzed, that's neurology, that's motor. You feel sad, anxious, you're seeing things, chemical, not motor, that's a psychiatrist. So we've artificially divided the brain. There's no division. There's an artificial division of kind of neurology and psychiatry. It's a little bit deeper than that, but generally speaking, that's kind of how we divide it. And so med school is the same. Like I mentioned, I didn't know I was going to become a psychiatrist. In fact, I'm gonna be honest with you all. I kind of didn't like psychology. I kind of didn't like neuroscience. It was, in fact, I actually remember saying, I'll never do that stuff. Because I thought when I was in college and I was in pre-med, I was like, this is all hindsight bias. Oh, psychology, they were able to predict this. I'm like, well, it's hindsight bias. Like, oh, it's like you didn't really know that. You just look back and you say, oh, it was for this reason. I didn't really appreciate it. I only took really one psychology class ever in my life. That was in undergrad. Didn't do that well on it. I didn't take any psychology class in med school because it's med school. And then psychiatry, I didn't either. It's again kind of the psychopharmacology. But we do take therapy classes. Um, and even then, honestly, it's a little bit basic. And so I actually went out of my way, after the hospital and sought out further training in psychotherapy, um, to really kind of develop those skills. Honestly, you can spend your entire life training in psychiatry because there is so much training out there for different types of therapies and different populations and stuff. So, I mean, long-winded answer, but to say, med school is med school. It's the same. There is no difference if you're a psychiatrist or any other kind of doctor. Med school is the same. When you all apply to your residency, I happen to choose psychiatry. It's one of the residencies. And then in residency, you do training like you do any other residency. Psychiatry residency is 4 years. Internal medicine, for example, is 3 years. So we do a little bit longer residency. And by the way, gosh, like 4 years after residency, I'm still learning as much as I did my first 4 years of residency. It is unreal, like how big this field is. I had no clue. And I'm just telling you, if you all go into it, we'll be chatting at our annual conference together, and we'll be chatting about how unbelievable this field is in terms of growth, and it's just exciting. It's never boring, ever, never boring.
Awesome. So I want to be a psychiatry, not me, but somebody asked, I want to be a psychiatry physician assistant. Can I still make a wide scale change in my community, or do I need an MDDO?
Yeah, awesome. So absolutely, you can make a huge impact in the community. Number one, as a provider, obviously, like PAs are able to do a lot of the work that the psychiatrist does. You're, I guess, under the supervision or whatever of a psychiatrist, but you're treating patients, and it's essentially, the same thing. Um, so you're gonna make a direct impact in that way, like any other psychiatrist would. If we want to make a bigger impact, now we are looking at systems. And that's kind of our own individual undertaking, of which kind of I have also done. But that's kind of in addition to your clinical work. And so you don't have to be a psychiatrist to be able to have a big impact in society. I'll tell you one thing. So I was a big researcher at Stanford. Like I had an NIH funded position. Published actually last month, the largest twin autism study ever done with neuroimaging, specifically using this detailed MRI called DTI. It took 11 years to get to get that project off and published. And even then, the project continues at Stanford without me in different directions. Um, okay, all of that. I'm trying to say the research, amazing stuff, beautiful learning and discovering and all these things. How many people are going to read my paper? How many people are going to see a TikTok on mental health, or or a story on Instagram? Way more, exponentially more people are going to see that, and so in a way, like that kind of shows you what kind of impact you can have in your community by being engaged in these platforms nowadays, as opposed to the traditional kind of research, which of course we need because that's where we get our information from. But there are just so many ways to impact communities positively, where it's not through the one-on-one. I feel like obviously the one-on-one is important, but systems and access to people and disseminating information, I think, is huge. And you can do that whether you're a psychiatrist or not.
Our next question we have is, knowing that health insurance can sometimes limit the amount of covered appointments, how do we combat the health insurance limits for care?
Yeah, that's a great question. Complicated answer. I don't think I have the answer, but I have some ideas, right? So the common one is the single payer model, where everyone puts into the system, and then we all have access to the system. I think that that is a first good step. It at least gives access to people. That doesn't necessarily mean that they will actually have access, because we need enough providers to be available to be able to see these patients. And so the common answer is a single payer system, but we need to actually train enough physicians to be able to satisfy the needs of the population. So we got to work from both ends. Um, and for that, again, kind of going back to the previous question, you don't have to be a psychiatrist to really advocate for that, or for you to think about other solutions. The solutions are going to be multidisciplinary. What is the input from an economist? What is the input from public health people, from business people? Because things have to, whether we like it or not, they have to be sustainable financially. So how are we going to do that? You're not going to really convince a government to fund an idea unless you can show that that idea is financially stable, sustainable. So you can be in any field and have an equally important voice on this topic. And that opinion counts just as much as, a physician or some other, health provider. Um, so I guess in summary, I think one of them is single payer system. And then you can get creative and you can think of, well, what if we create another Kaiser type of system where it's from the ground up, people kind of pay into it, and then you provide your own little healthcare system. Um, Lots of ideas, lots of challenges, but lots of opportunity to help.
Our next question, some doctors are able to get their master's along with their MD. So what is the purpose behind getting both?
Yeah. So I mean, I was one of them. So the purpose, in my particular case, was exactly to do the things that we've been talking about. How do we positively impact communities? Not just one-on-one, patient visit by patient visit, but large scale things. So I got a master's in clinical study design and epidemiology, right? The study of disease at a population level and how to design research studies. Part of the reason why I got that degree is because I wanted to be able to understand the science in studying the problem. So the problem of access to healthcare because of the issues of insurance. Well, in order to solve the problem, we need to find and define the problem. So how are we going to study the problem? What's the study design? So that's why I got my master's in that. My peers, my classmates in med school, because I went to the Prime LC program. So Prime is a program that the UC medical schools have that is to if you get into the Prime program, you're going to get your medical degree because you're in med school, but they also give you time to get your master's for this purpose, for the purpose of educating you and thinking of ways to help populations at large. And I did it through a master's degree in clinical study design. My friends did it in an MBA, a master's in business administration, an MPH, a master's in public health. All of it is useful. Like we all kind of are coming together to create ideas and put them into action to be able to help. So that's why we did it. Got the master's along with the MD. Other people will get the master's to kind of, believe it or not, improve their application for residency. So, not to scare you all, but just make you aware, like you're pre-med and it's like, very hard and you're trying to get into med school. You kind of go through that again in med school to get into residency. It's competitive, right? So, like psychiatry residency at Stanford, where I went, there's only 12 positions. These are everyone in the country that is going to psychiatry. Most people are applying to Stanford and there's only 12 spots, right? So it's how do you stand out? And so everyone went to med school. How do you stand out? Right. And so people end up getting masters to be able to stand out. So it's kind of an unfortunate in a way. I mean, it's fortunate because like people are getting more educated and hopefully they're using that education to actually make change in their communities. But some people just kind of feel obligated to do that to stand out. So that's another reason why people do it.
Our next question we have is, where do you think is the best place to volunteer or work if you're trying to submerge yourself in the psych community?
Yeah. So I kind of shared the story about my first exposure to psychiatry in that inpatient ward with that very nervous patient. Um, because like that experience was just purely like emotional for me, right? Like it was just like a tough emotional moment that I had to deal with. Um, and when I actually did my psychiatry rotation as a medical student, I didn't really understand what the residents were doing, what the attendings were doing, because I didn't know the diagnostic criteria, I didn't know the medications. And so I didn't get to appreciate really what they were doing. It's hard to appreciate that. So I would say that whatever kind of volunteer exposure you have, don't expect to show up and be like, wow, like, oh my God, like this is so cool. Like you kind of have to like educate yourself on like how to diagnose, like what's the criteria so that you can appreciate, oh, that's what they're asking. Like when they ask like oh, like what'd you do this weekend? It's not just a filler question. Like they're actually trying to get at something. Like what are they trying to get at? So then the interviews, the assessment become very interesting when you have that background knowledge. So where you can volunteer it's tough because everyone has different policies, right? But places you could potentially volunteer would be obviously a hospital. The way I did it was I was a Spanish interpreter. So, and I volunteered as a Spanish interpreter. So I got access to patients and I could hear what the physician was saying. That's one. Um, Scribing, if you can get paid, even better. But that's another way to have access to the patient and the physician. Um, I guess shadowing, maybe in the community clinic or physicians that you may know. If you know a physician, whether they're psychiatrists or not, ask them like, "Hey, do you know of a psychiatrist that you can put me in touch with that maybe I can shadow?" It may or may not be possible. As you can imagine, these appointments can be sensitive depending on what the person is talking about. So, but there will be some that are kind of like, not as intense. Patient may not mind you being there and you can get to observe. But my recommendation is find the volunteer opportunities like you would any other, but prepare yourself for them because then that's how you're really going to get the most out of it.
Yeah, I just put a link in there. There's the text crisis um, you could do, and you could basically do it from home on your cell phone.
That's a good one.
You basically get trained. I think you have to do like 24 hours or 32 hours, something you have to go through, and then you basically become a first line volunteer that you basically answer the call and they train you if it gets kicked up. Uh, Also, every county has a crisis center that you could volunteer for. There's like you could do health fairs, you could do, and then also there's jobs now. Basically, the California Department of Public Health is paying undergraduates to work at the local health departments and address these issues. And some of them pay like 22 bucks an hour. And so you get training and exposure, and you're more likely to work with social workers, and mental health providers that you could do a lot of those things. So, um, you know, Google is a great invention to find things. I don't know where this person is, so can't really tell where I could tell you to go, but there's a lot of resources and we've posted some of them and yeah, and so there's a lot of things you could do. Obviously, the best way you could help is go become a psychiatrist, but there's a lot of things you could do in between.
Absolutely. Yep. And in fact, I think those experiences there would actually help you because when I recommend like the crisis text line, um, if I was someone who had already worked there, I know, inside knowledge of like how that looks and how that can help a person, or maybe some of the pitfalls. So it all counts. It's all really important.
All right, our next question. Do you feel like psychiatry gives you the option to give longitudinal care, or are you always working with new patients?
Yeah, so I love longitudinal care and I'm absolutely yes able to do that. Now sometimes they will move on after a year or so, and so it's not like primary care where you might see someone for like decades. But psychotherapists sometimes do see patients for decades, like they had a really good connection. The person had a really good connection with the therapist and that's like their therapist for life. So that certainly does happen. Um, and um, so the way that I would say, unfortunately, the way that most clinics are set up, because they are sadly patient mills, patients just kind of coming through. Um, there's not a lot of continuity. Part of the reason why I went into private practice was to be able to have that continuity. And what I'm currently working on is creating a structure in private practice where I can then increase my volume and start looking like these community clinics, but with private practice kind of quality of care, which includes that longitudinal care. So the answer is you can have longitudinal relationships with your patients. You may have to create the opportunity for yourself, like in private practice. You might be able to find it in some clinics, some community clinics. But otherwise, it's gonna be like, working in the hospital, stabilizing, discharging, or working in a outpatient clinic where patients kind of come in and out and maybe get evaluated, get some medications or something, and then get transferred back to the primary care. And the primary care does refills, and the patient only comes back if there's been a significant change.
All right. Our next question we have is, they're just letting you know that they're a first-year community college student and they've been leaning on psychiatry for a while, and they've come to learn that they genuinely love the science and math behind everything. So their question is, as a psychiatrist, how often do you find yourself thinking about the science behind it all when diagnosing or working with patients? Are there any other ways to continue research or applying science while being a psychiatrist?
Yeah, so I think this depends on how you practice psychiatry. So, again, if you like a lot of therapy, you're probably not going to be thinking a lot about the traditional science that you're saying, like the pre-med science, the pharmacology, the physiology, the pathophysiology. Probably not thinking as much about that. You're thinking about, you know, the way that psychologically someone is organized. So it's still science, but it's not the like the basic science type of stuff, more on the psychology side of things. Um, for my case, I think about the science all the time. So I'm thinking about dosing, the half-life of a medication, like what's the metabolic rate at which you're breaking it down, how long is that medication in your system, how quickly can I escalate the dose, how quickly can I bring it down, how is it interacting with your kidney, with your liver, with your heart, how is it interacting with other medications you might be taking, how is it going to affect any current symptoms you have? Yeah, I mean, I'm ordering lab tests. I'm ordering scans, EKGs to check how is the electrical activity of your heart before and after starting a medication, just to make sure that everything is okay. Yeah, the medicine is very much present in every appointment, if that's the kind of psychiatrist that you want to be. Um, in terms of how do you stay up to date, it's tough because, once you graduate, like you're living your life, you may have a family, you're busy seeing patients all day, like every day. And, but it is important to stay up to date. And so the ways to do that would be going to the annual specialty conferences. So like every specialty has their annual national conference. For psychiatry, it's called the APA, American Psychiatric Association. Our annual nationwide conference occurs every May. We know May blocked out. I'm going to go to my conference, get up to speed with all the latest research, all the latest diagnostics, and latest treatments. It's 1 week where you're catching up. That's one way of doing it. Signing up for the journals, you get the journals in the mail. You read the articles on kind of like what's the updates on things. Um, and then here's the beauty of it, of one thing actually. Um, you can attend some grand rounds. So like, if you're in actually now virtually, you could be anywhere. I haven't done this myself, so I don't know for sure, but I'm probably you can attend grand rounds and these big academic programs, as prestigious places like in the East Coast. You can probably do it here at Stanford. I know that the Stanford grand rounds, back when I was there, when they were in person, were public. Like sometimes when it was something specific, they would close it for just the department. But otherwise, it's public. You can literally go to grand rounds psychiatry at Stanford, sit in there with all the physicians and all the staff talking about the latest on this particular topic. And it happens every week. So grand rounds is another way to stay in touch with the research and the latest.
All right, so do my extracurriculars have to be diverse, or can I solely focus on mental health extracurriculars if I'm wanting to go into residency for psychiatry?
I would say do what you want. Honestly, when I'm looking at the applications, in the past, when I've looked at applications for people coming into medical school or applying to residency, the thing I look for is passion. That's the number one. Like I kind of don't care exactly for the most part what it is, because you're probably doing something great. But it's that passion. I want to see what are you passionate about, and it's look you can't lie. Like it's gonna come through if you're not passionate about something. It's gonna be obvious in terms of like how much you actually did or how much time you spent on it or the way you talk about it. Because if I interview you and you're telling me you're passionate about something that I happen to be passionate about, I'm going to know a lot about it and I'm going to be able to see if you're passionate about it or not? And so my answer to that is it all counts. You don't have to worry about it. If you love writing, you like poetry, it counts. Imagine being able to write, you know, beautiful, poems or short stories that are like mental health related and teaching people about a topic or a perspective. That's beautiful. Like, please do it. So anything and all of it counts. So my suggestion is don't worry about that. You can always find a way to tie it all in, and you should, for the purposes of like, presenting yourself. Um, but follow your passion. That's the most important thing.
All right, our next question is, how did you decide to go into practicing versus research?
That was so hard. Oh my God. Man, that's a hard one. So, as a pre-med and as a med student, we're, interacting with these academic centers, and research is so highly valued. It's like the thing that you're supposed to do. And then I got a research position that was NIH funded, and my professors were like backing me up. And I, it was like hard. I felt like, oh my God, am I betraying them? Like they've invested so much, in me, and they had so many hopes, and it was one of the hardest things to be honest, to break out of that. I don't regret it, any of it. Like I worked really hard in research and I loved it. And I work now really hard out of research and I love it. I still do research. So anyways, I'll mention this now and maybe I can coordinate with people to put this on the site. But if you're interested in research, like I'm always doing case studies and all this stuff. So like if you're pre-med and want some research exposure, reach out to me. I can put you on one of my projects. So I still do it. I just don't do it at the level of like neuroimaging, where we had a super fancy MRI machine and I actually use the Stanford supercomputer to analyze my data. And yeah, I don't have access to that anymore, right? But I still do research at a different level, more on the patient level. Um, but it was very hard to break out of that because so much had been invested. I'll share with you something that is, I think, very different. And I don't know how much of this will make sense to you all, but I think this is a perspective I share with a lot of med students and residents because they're more advanced in their training and they kind of understand what I mean by this. And that is, um, I feel like science research is beginning to move a little bit away from academic centers, at least in this area in the Bay Area, because we have so much tech, so much funding that a lot of people I know have left academia to pursue their research endeavors in the private sector because there's enough money. You don't have to apply for the NIH grants and wait like a year. There's enough money, there's enough interest, and there's enough brain power in the area to just kind of put things together. And it's a lot faster. And so you get results a lot faster. So I had one of my mentors, very famous psychiatrist. He trained, his research training was at NIH. Back in his generation, you didn't go to Stanford, you didn't go to UCSF, you didn't go to Harvard to do research training. You had to go to NIH. That's where the stuff was at. Over time, these institutions started investing in their research programs and saying to NIH, hey, instead of you spending the money and you having to worry about setting up the lab, send us that money. We worry about setting up the lab. We train people here. And it eventually shifted where the best research training you got in some fields was going to be at these institutions, no longer at NIH. I feel like our field is moving forward where it's no longer going to be the institutions. And if you want the most cutting edge stuff, it's going to be in the private sector. Um, so that's not something that a lot of people, no one in academia wants to hear that, I think. And there's probably a lot of people that will disagree with me. I think there's a role for everything. NIH is still here. Academic centers will still be here. But I think the private sector, the tech sector, the biotech is going to keep growing and it's going to play a crucial role in being at the frontier of development.
All right. So would you say it's common for psychiatrists to specialize in psychotherapy?
No, it's not. And that's more of a economic reason. Psychiatrists are expensive. We're the most trained. We've been in school for, I mean, think about it, right? Like 4 years of undergrad, 4 years of med school, 4 years of psychiatry residency minimum. I took a gap year between undergrad and med school. Then I took 2 extra years in med school for my master's degree. And then I was going to take more time after residency for my postdoc training and research. So like we're talking about, 15 years or whatever. Like, it's a long time of training. So anyways, we have tons of debt, in general, like out of all the mental health professionals, we're going to be the most expensive ones. That's just how it is, right? Okay, if that's the case, and you have to see a psychotherapist every week, you're probably not gonna, not a lot of people are gonna be able to afford the psychiatry prices on a weekly basis. And so even though psychiatrists would want to do therapy every week, either they significantly reduce their rate so that it becomes accessible to people, at greater frequencies, or they don't. And then they end up being stuck in the medication management. When you work in a clinic, you don't have a choice. The clinic, the business people are saying, we need to generate money. You make the most money diagnosing and treating with meds. This other group of people, the social workers, the licensed marriage family therapists, etc., they make their money doing the therapy, and that's how it gets divided. So it ends up being for an economic reason. If you're in private practice, you can do whatever you want. You can lower your prices. You can say, hey, my price for medication management is this. But if you transition to just psychotherapy, it can be this. You have full flexibility. But most psychiatrists don't have that. So they end up doing most of the medication management.
All right. Our next question we have is, you mentioned that cost is a major barrier to accessing psychotherapy. Is this a referral that is not considered standard of care and is therefore not covered by insurance? And how can we help better address this disparity?
Yeah. So it is absolutely standard of care and it is covered by insurance if the psychotherapist is on the insurance panel. Now, many, if not most, psychotherapists are not on the insurance panel. So that means that they're out of network. And depending on your plan, the plan will pay, I don't know, 30% or 50% or whatever, 70% of your out of network outpatient mental health care, So it varies from plan to plan. But the reason why it's expensive is because most therapists are not on the insurance plan, and those that are completely full. So, patients aren't able to see a therapist until it's been like, months of waiting. And so oftentimes patients can't wait that long and they end up paying for, the private practice people, the private practice therapists. So, um, and then the question about like, okay, well, why don't more therapists join the insurance panels? I mean, it's a good question. Uh, I'll tell you the answer for most of us is that we're a little bit scared of the insurance companies because what they do is that they will pay you. Well, first of all, they might make it difficult to pay you as a provider because they'll say, oh, well, you didn't put the right code down, or that code doesn't fully make sense, or you only mentioned 3 out of the 5 points that you needed. Like very detailed things that honestly are complete BS. It's just meant to make your life harder so that they don't pay you. And so then you're having to deal with calling me on the phone and resending notes or billing to just get the payment that you needed. And so for that reason, a lot of providers just say, you know what, I'm a solo provider. I'm trying to see patients. I'm seeing patients all day. Unfortunately, I don't have time to troubleshoot that. I don't have a billing department. And so I just can't. I just can't take that insurance. And so that's the the sad reality of that. And now in clinics that do take insurance, well, those clinics are like the patient mills that I was saying, kind of get the patient in and out, and then that kind of reduces the quality of the care. So that's the current kind of status of that situation.
So it does look like we have no more questions in the chat. If anyone does want to ask any more questions, please put it in the Q&A now.
Or forever hold your. Alrighty. Well, since we don't have any more questions, and it's 7 minutes, 8 minutes past our time, um, I don't have any other questions. So, and if anybody has any questions, you can send us an email. I put our email in the chat, and yeah. And so, well, thank you again, Dr. Montero, for coming and
Pleasure.
spending your Saturday morning with us. I'm sure there's more. It's a beautiful weather out, so
It's really nice out, but I'm happy to be here. Thank you for the opportunity.
thank you again, and everyone have a great weekend and catch you on the next one.